So next up is Dr. Shanu Modi, who is professor of medicine and head of the HER2 positive breast cancer service at Memorial Sloan Kettering Cancer Center. Shanu has extensive experience with antibody-drug conjugates, including major roles in the development of both T-DM1 and Trastuzumab deruxtecan. She will be speaking about ADCs in breast oncology, present and future. Thanks, Shanu.
Thanks. I'm so glad you all saved your hard questions for Reshma Pooja. As we just heard, the rationale for developing antibody-drug conjugates was really to try and overcome the limitations of cytotoxic therapy. So specifically overcoming or improving the therapeutic index. And so let's review now the clinical impact that these ADCs, these novel drugs, have had in the treatment of our patients today. And just to orient you, we'll talk about the HER2 targeted drugs, the Trop2 targeted drugs, new drugs in development, ADCs in development, and then future directions. So of course, the prototype and the first approved ADC in breast cancer was T-DM1. And this is a monoclonal antibody that's Trastuzumab with a non-cleavable linker and a tubulin targeting payload. And when T-DM1 was first made available clinically, it really was a profoundly important drug and a groundbreaking drug in breast cancer. The trial that led to its approval in HER2-positive metastatic breast cancer, of course, was the Emilia trial. This was a study comparing T-DM1 to standard capecitabine plus lapatinib. And not only was T-DM1 superior in terms of efficacy, it also had a more favorable safety profile. So it really did fulfill the promise of ADC therapy. And it's become our standard of care, or had been our standard of care, second-line therapy for close to a decade. Of course, T-DM1 also has an important role today in early-stage HER2-positive breast cancer, specifically for those patients post-neoadjuvant therapy with residual disease, where in the Catherine trial, we saw that patients who received T-DM1 had a 50% reduction in their risk of recurrence. And so it has also become a standard of care therapy in this high-risk early-stage setting. Of course, T-DM1 has had its setbacks. In the Marianne trial, it failed to prove superiority to our first-line paclitaxel plus Trastuzumab regimen. And it also did not show improved efficacy against standard chemotherapy combinations in improving path CR rates. So these failures, I guess, of T-DM1 have in part been attributed to its limited activity in tumors with low levels of HER2 expression and HER2 heterogeneity. So Trastuzumab deruxtecan is a new generation HER2 antibody drug conjugate. It shares the same monoclonal antibody backbone as T-DM1, but has a novel payload linker technology that has allowed it to have some unique characteristics and the potential to overcome the obstacles or limitations of T-DM1, specifically a topoisomerase 1 inhibitor payload, twice the number of chemo molecules linked to each antibody, and most importantly, a cleavable linker, which, as we heard, facilitates the bystander effect and allows T-DXd to be active in cells with various level or variable levels of HER2 expression, so the potential to overcome HER2 heterogeneity. So the first trial that really, I think, was an important study for T-DXd in breast cancer was the DESTINY-Breast01. This was a straight phase 2 study for patients with heavily pretreated HER2-positive breast cancer who had previously received at least 6 lines of therapy on average, and specifically T-DM1. And we saw very striking activity as shown here in the waterfall plot, much more than we could have anticipated for this late-line setting. We also learned a lot about the tolerability of T-DXd. It largely has GI and bone marrow suppression toxicities, but manageable with prophylactic interventions. And of course, we also learned about the lung toxicity risk. Thankfully, for most patients, it's a low-grade toxicity, but there is the potential of rare but fatal ILD. And so this is a drug that requires strict vigilance and early intervention to keep or minimize that lung toxicity. And so overall, the DESTINY-1 was really the trial that led to the initial approval of T-DXd as a therapy for our patients in the third-line setting. Of course, at this meeting, we just heard the results from what was really the planned follow-up trial to DESTINY-1, that was DESTINY-2. So this is a randomized phase 3 study, again, for patients with HER2-positive metastatic breast cancer who'd previously been treated with T-DM1. And here, patients are randomized to either T-DXd or physician's choice of capecitabine plus trastuzumab or capecitabine plus lapatinib. All patients, of course, had prior T-DM1. They had prior trastuzumab. 80% had pertuzumab. And on average, there was a median of 2 lines of prior therapy. But in fact, these patients had received among the most effective HER2-targeted therapies that were available at that time. And so these were the efficacy curves we saw this morning. On the left, the PFS with a hazard ratio, a significant hazard ratio, which I can't see, of 0.36 in favor of T-DXd. And on the right, the key secondary endpoint of overall survival, also a hazard ratio of 0.66 in favor of T-DXd. In terms of overall ILD risk, we saw a rate of 10% in this trial, with 2 reported cases of lung toxicity that were fatal, so 0.5% incidence of grade 5 events. Overall, the results of the DESTINY-2, I think, are really compelling and suggest that not only is T-DXd more effective than our standard chemotherapy approach, but it also is proven to be active post-T-DM1. So normally, results like DESTINY-2 would really, I think, capture the oncology headlines, but not this year because it was overshadowed by the updated results of the DESTINY-Breast03 trial, which was also presented this morning. And as you know, this is a randomized phase 3 study, which is a head-to-head comparison of the 2 HER2 ADCs, T-DM1 versus T-DXd. To remind you, in this trial, all patients had prior taxane and trastuzumab therapy, and 60% also received pertuzumab, and 40% of the population in this trial had received only 1 line of prior therapy, so there's a large second-line population of patients on this study. And these are the updated PFS curves. They were pretty astonishing when we saw them the first time, and I think they remain so now that the hazard ratio for PFS is 0.33 in favor of T-DXd. And you can see here, and we've now actually seen the establishment of a median PFS, which is 29 months. That's 4 times longer than T-DM1. It's pretty spectacular. I think it's also important to look at the early part of the curves where you see just how effective T-DXd is at preventing the early progression events that happen on the T-DM1 arm. Even more important, for the first time, we saw the overall survival results at the second interim analysis. Here, the hazard ratio for OS is 0.64, again, in favor of T-DXd. Of course, median overall survival hasn't been reached for either arm. But you see the curves really started to separate early, and they've maintained their sort of absolute 8% difference over 2 years of follow-up. I think it's also exciting to see the persistent response rate, so still seeing an almost 80% response rate for this monotherapy. And what's increased is the complete response rate, which is now 21%. So 1 out of every 5 patients treated with T-DXd has complete regression of their measurable disease. It's also remarkable to see the median duration of response at 36 months. So patients who respond to T-DXd can stay on this therapy for a very long time. The one, I think, really reassuring thing about the DESTINY-3 data has always been its safety, and specifically ILD safety. So although the overall rate has increased to 15%, they have still not reported any grade 4 or grade 5 cases. So if you weren't a believer before, I think the results we saw this morning certainly support T-DXd as the superior HER2 antibody drug conjugate and the preferred second-line therapy for HER2-positive metastatic breast cancer today. All eyes are now on DESTINY-Breast09. This is the first-line randomized study comparing T-DXd to the Cleopatra regimen with a third arm of T-DXd plus pertuzumab, very reminiscent of the Marianne design and potentially a practice-changing trial. Of course, T-DXd has already entered into a couple of early-stage studies. The NSABP60 or DESTINY-5 is very similar to the Catherine trial. It's for patients with residual disease post-neoadjuvant therapy who are now going to be randomized to either TDM1 versus T-DXd. And the DESTINY-Breast11, which is the neoadjuvant study for high-risk early-stage HER2-positive disease. Of course, in continued distinction to TDM1 and in line with its mechanism of action, T-DXd has also shown activity beyond HER2-positive breast cancer. So the DESTINY-Breast04 trial is the first randomized phase 3 study of T-DXd versus physician's choice of chemotherapy for patients with HER2-low metastatic breast cancer. And just to remind you, patients in this study had HER2-low defined by IHC scores of 1+ or 2+ without gene amplification, 1 to 2 prior lines of chemotherapy, and for the hormone-positive patients, a disease that was considered endocrine refractory. And of course, patients were randomized 2-to-1 to T-DXd versus the physician's choice of chemotherapy. And these were the efficacy curves previously presented for all patients on the trial. On the left, the PFS hazard ratio 0.5, and on the right, the key secondary endpoint, overall survival hazard ratio 0.64, both solidly in favor of T-DXd. In this trial, the ILD rate was 12% overall, with a 0.8% incidence of grade 5 events. So we're consistently starting to see a less than 1% incidence of high-grade events, a big distinction from the early DESTINY-Breast01 trial. So based on these results, T-DXd is now the standard of care treatment for patients with HER2-low metastatic breast cancer. The final, I think, activity of T-DXd or its ultimate role in breast cancer, I think, is still yet to be determined. We've seen some very provocative data from the DAISY trial that shows activity for T-DXd also in patients with IHC 0. So currently ongoing is the DESTINY-Breast06 trial. This is another randomized study for patients with HER2-low metastatic breast cancer. Patients will be receiving either T-DXd or physician's choice of therapy. All patients have not had in this trial prior chemotherapy, so it's a test of T-DXd as a first-line systemic therapy post-endocrine treatment. This trial also includes, or prospectively includes, a cohort of 150 patients with ultra-low HER2, that's IHC scores less than 1+ but greater than 0, to try and see if we can further refine the lower boundary of HER2-low and expand this therapy to a larger population of patients. This morning, we also saw first results from the first neoadjuvant trial, or early results from the first neoadjuvant trial in HER2-low breast cancer. This is the TALENT trial. Here, patients with hormone-positive HER2-low early-stage breast cancer were randomized to either T-DXd or T-DXd plus endocrine therapy. Initially 6 cycles, but later the trial was amended to include 8 cycles of therapy. This is a small study, and at this point, it's too early to draw any conclusions about path CR rates, but I do think the trial is instructive in showing us that we can safely deliver 6 to 8 cycles of T-DXd in the neoadjuvant setting, and there's certainly a tremendous wealth of translational research that will allow us to better understand the mechanics of T-DXd from this trial. We have, of course, seen promising activity for T-DXd in the treatment of HER2-positive breast cancer brain metastases, with intracranial response rates ranging from 44 up to 73%. So very exciting to see activity like this from a systemic agent. Currently underway is the real-world Destiny Breast 12 trial, where half the patients enrolled will have brain mets at baseline, and this will give us a larger experience with T-DXd in the treatment of brain mets in this setting. T-DXd is also the first therapy to be approved for patients with HER2-mutated cancer, and specifically non-small cell lung cancer. This is a waterfall plot from the Destiny Lung 01 trial that led to this approval. Of course, HER2 mutations are seen at low frequency in multiple cancers, including breast cancers. And so there is a basket study as well of T-DXd for solid tumors with HER2 mutations and includes breast cancer. So overall, T-DXd is a really exciting and versatile new generation HER2 ADC, really unique by virtue of its novel linker payload technology. It's currently, in my opinion, the most effective HER2-targeted therapy that we have in the clinic. It's allowed us to expand HER2-targeted therapy into new populations and settings. Of course, it overall has a manageable toxicity profile, but does require strict vigilance to minimize the risk of lung toxicity. And I think we can expect to still learn more about this drug as these trials mature. So what else is in the HER2 pipeline? So there are a number of HER2 ADCs in development, some with novel payloads, some with novel antibodies. We have already seen positive phase 3 results for Trastuzumab duocarmazine. Here, the payload is a DNA alkylating agent, so a novel mechanism of action. In the phase 3 TULIP trial, where Trastuzumab duocarmazine was compared to treatment of physician's choice, the PFS hazard ratio was 0.64, and in favor of the ADC. Given that it has a cleavable linker, it's also shown demonstrable activity in HER2-low metastatic breast cancer, seen in the waterfall plot below. And although there are eye and lung toxicities that once again require vigilance while patients are on this treatment, it is currently under regulatory review. Zanidatamab zovodotin is another HER2 ADC with a unique antibody this time. It has a bispecific, so it targets or binds to 2 different epitopes on HER2. So this allows for a more rapid internalization of the antibody. In the ADC, there is conjugation to an auristatin payload, and we saw some nice phase 1 activity, early activity in a phase 1 trial of multiple tumors expressing HER2. Disitamab vedotin, or RC48, is another antibody with a unique, or another ADC with a unique antibody, Trastuzumab, which binds to a non-overlapping region to Trastuzumab. It too has shown activity in both HER2-positive and HER2-low metastatic breast cancer, and is already in a randomized phase 3 trial for the latter setting with a design very similar to Destiny 4. Moving on now to the Trop2 targeting ADCs. As you know, Trop2 is a widely expressed transmembrane target present on almost all subtypes of breast cancer, and particularly on triple-negative breast cancers. So Trastuzumab govitecan is a first-in-class Trop2 ADC. It also has a cleavable linker, a topoisomerase inhibitor payload, and a drug-antibody ratio of 8, so a lot of similarities actually to T-DXd. The phase 3 ASCENT trial was the registration study for Trastuzumab govitecan, and it enrolled patients with heavily pretreated metastatic triple-negative breast cancer who were randomized to either the ADC or treatment of physician's choice. And as shown here, this trial hit both its primary and secondary endpoints with the PFS and OS advantage in favor of Trastuzumab and hazard ratios of 0.41 and 0.48. Although it does have more grade 3 diarrhea and bone marrow suppression, there was less discontinuations on the Trastuzumab arm than standard chemotherapy. So this is really a deliverable therapy. And based on the results of the ASCENT trial, Trastuzumab was the first Trop2 ADC to be approved and the first ADC to be approved for triple-negative breast cancer. Trop2 is also expressed on hormone-positive breast cancers, and so the TROPiCS-02 trial was the first randomized phase 3 study of sacituzumab, again, versus treatment of physician's choice for patients with hormone-positive, HER2-negative metastatic breast cancer. Here, patients had between 2 to 4 lines of chemotherapy and prior treatment with a CDK4/6 inhibitor. And these are the efficacy results. On the left, the progression-free survival, again, in favor of the antibody-drug conjugate. And on the right, the overall survival with a hazard ratio of 0.79, again, in favor of sacituzumab. So this trial hit both its first and primary and secondary endpoints. And the NCCN has already endorsed sacituzumab as an option for hormone-positive, HER2-negative metastatic breast cancer patients while we await regulatory approval. There are, of course, a few Trop2 ADCs in the pipeline. Furthest along is datopotamab deruxtecan, and as the name suggests, it has the same linker payload technology as T-DXd. In a phase 1 trial of patients with metastatic triple-negative breast cancer, the overall response rate with datopotamab was 34%. Interestingly, about 30% of the patients on this trial had previously received a topo-1 ADC as prior therapy, and so when we removed that pre-treated group, the overall response rate improved to 52%. So clearly some cross-resistance between these two ADCs, as you would expect. Datopotamab certainly has a different safety profile than sacituzumab. It has less GI and bone marrow suppression, GI toxicity and bone marrow suppression, but has more stomatitis and nausea. Overall rates of discontinuation, however, are very low, close to 1%, and no cases of ILD have yet been reported. Given the importance of IO therapy in triple-negative breast cancers, we are seeing combinations of datopotamab and IO therapy, in this case from the Begonia trial, a first-line study looking at datopotamab plus durvalumab with an overall response rate of 74%. Very exciting. Recall the monotherapy response rate was 52%. So you'll definitely see these combinations move forward. In fact, here are a bunch of ongoing or current ongoing or planned studies for both sacituzumab, those trials are on the left, and datopotamab on the right. You can see at the top here, both drugs have entered first-line metastatic breast cancer trials, and similarly, they have both entered first-line metastatic triple-negative breast cancer trials for PD-L1 positive patients as well, in this group, of course, including IO therapy. These are the trials ongoing for hormone-positive, HER2-negative metastatic breast cancer. On the top left, sacituzumab plus minus pembrolizumab, and on the top right, the TROPION-Breast01 trial comparing datopotamab to investigators' choice of therapy in a less pretreated population. And finally, on the bottom, there are already trials underway for residual disease, for the residual disease setting as well, the Saskia on the left and the TROPION-03 on the right. We got our first glimpse of the benefit or the activity of sacituzumab in the neoadjuvant setting from the NEO-STAR trial. This is for patients with triple-negative breast cancer. With 4 cycles of sacituzumab, we saw a path CR rate of 30%, much more robust, you can see, in the germline BRCA patients, and we will certainly see future trials build on this. So what is in the pipeline? There are, of course, a number of ADCs in development also looking to target novel antigens. This is by no means a complete list, but to give you an idea of some of the drugs in development, patritumab deruxtecan is a HER3-directed antibody-drug conjugate, again, the same linker payload as T-DXd. HER3, of course, is expressed on multiple tumor types, up to 50% on breast cancers. It is a dynamic protein and is associated with a poor prognosis. And we saw results from a phase 1 trial of patritumab in HER3 expressing metastatic breast cancers. Impressive overall response rates were seen across all 3 types or subtypes of breast cancer, and this included durable anti-tumor activity. This drug is already in multiple phase 2 trials in combination therapies, both in the early stage and metastatic setting, and has already moved into a phase 3 trial for non-small cell lung cancer. Deruxtecan vedotin is an ADC targeting LIV-1. Again, LIV-1 is a transmembrane cell adhesion molecule found on multiple subtypes of breast cancer. This ADC has a cleavable linker as well and an MMAE payload. It's been tested in multiple schedules and doses across all subtypes of breast cancer. Shown here are the results in triple-negative breast cancer with monotherapy and in combination with IO. And it is currently enrolling in a phase, in a first-line study for metastatic triple-negative breast cancer in combination with pembrolizumab. And finally, enfortumab vedotin, a Nectin-4 targeting ADC. The Nectin-4 is a cell adhesion molecule highly expressed in epithelial cancers, including breast cancer. Of course, this is a waterfall plot from a urothelial cancer trial where enfortumab is now an approved agent. A basket study of this ADC, which included 2 arms of breast cancer patients, has completed accrual, and we're awaiting some preliminary results. So as we heard, I mean, there's a lot of excitement about the next generation of ADCs. Given their modular nature, there's a potential to make all different kinds of adjustments to these unique therapeutics. So we are now going to be seeing ADCs without antibody backbones, novel payloads that are non-cytotoxics, and also interested in looking to see if the next generation of ADCs targeting non-cancer antigens, so antigens within the microenvironment and on immune cells. So still a lot of exciting things to stay tuned for. So what's next, and what are the challenges and future directions? I think a clinically critical and emerging, rising problem for clinicians is how do we best select and sequence these ADC therapies? So already in the clinic today, there's a large population, an overlapping population of patients with HER2-negative metastatic breast cancer for whom we have the potential to use both T-DXd and sacituzumab. And to complicate this more, while they have different antigen targets, they both have a topoisomerase inhibitor payload. So does it even make sense to sequence these, or should we be looking at the other agents in development? I think as was talked about earlier, I think one area where we could really benefit from is novel predictive biomarker development. This would help rationally select and deliver these therapies. So for example, quantitative markers of payload expression, novel biomarkers of expression of the target, of the payload target, and also looking at novel technologies like AI to look at spatial heterogeneity and distribution of targets with regards to drug sensitivity. It's clear we also need the proper comparison and sequencing studies to allow us to select between these and to really chart out the long-term course for these patients, and several of these studies are under planning. Of course, rational combinations to sort of augment the activity of ADCs are important, and many are underway, not only trying to potentiate the cytotoxicity of the payload, but also promote anti-tumor immunity, and of course also take advantage of the mechanism of action of ADCs, so increase target expression or internalization dynamics of the receptor. Fundamentally, we need a greater understanding of the mechanisms of resistance, and this will allow us to, I think, really advance the field, and we will leave our next speaker to educate us on this. I think finally, without these tools available to us today as clinicians, we're really relying on cross-trial comparisons and safety cross-trial comparisons to guide our treatments. So if we come back to the clinical dilemma that we all face today, what do we do with that HER2-negative metastatic breast cancer patient who's eligible for both ADCs? I think one approach is to look at the HER2 status, and particularly for the hormone-positive, HER2-negative patients. If they have an IHC of 1+ or 2+, they would be candidates or good candidates for Trastuzumab deruxtecan based on DESTINY-4. For those with an IHC score of 0, Trastuzumab govitecan based on TROPiCS-2. And of course, for those patients who have hormone-negative, HER2-negative metastatic disease or triple-negative breast cancer, while there is compelling data in DESTINY-4 for activity of T-DXd in HER2-low hormone receptor-negative metastatic breast cancer, I think if we look at the wealth of the data, and the level 1 data is really from the Trastuzumab arena, and so this would be an appropriate, I think, option for that setting. The real question is, what comes next? Do we cross over? Do we look at different options? This is a question for research. And again, in the clinic tomorrow, these are decisions that we're making jointly with patients based on individual risk and benefit decisions. So to summarize, the technological advancements have brought us into a really exciting era of ADC therapy. These next generation drugs have improved efficacy, they have broader clinical applicability, and we've expanded the target antigen landscape. We're very excited about the next generation of drugs already. But really, to advance the field clinically, we need biomarkers of response. We need well-designed trials of sequencing and an understanding, again, of resistance to truly try to personalize ADC therapy. And I'll end there. Thank you.
Thank you for that great talk. Questions for Dr. Modi?
Paolo Tarantino, Dana-Farber. Thank you for this wonderful and comprehensive presentation. I have one question of something that caught my eye this morning, and it's something that probably we shouldn't do, but inevitably sometimes we do. That is doing cross-trial comparison, and in particular among the comparator arm of DESTINY-Breast02 and 3. And T-DM1 in DB03 at 6.8 months of PFS, and treatment of physician choice at 6.9 months of PFS in DB02. Do you think that this tells us anything in a post-pertuzumab era, or just that probably trials were different and populations were different?
Thanks, Paolo. I think you kind of answered that question yourself. The trials are different. I mean, the populations were certainly different. But you're right. I do think there is something about that. We saw the same PFS for the control arm. And so you do have to wonder, maybe this is the best we get post-pertuzumab therapy. And that may really be the one thing we can take away or discern from the clinical data that we have. But yes, I noticed that as well, very similar for those different trials.
Thank you.
Hi.
Bill. Hi.
Yes. Hi. Saikov from Rhode Island. The announcement of the durability of responses to T-DXd in DESTINY-Breast03 is very impressive, but it does raise the question for me, I mean, should we be treating patients, especially those who achieve a clinical CR, for that long? I mean, given the toxicity, the expense of treatment, I mean, are there patients in whom we could stop treatment?
I think that's a great question. And I think many of us have that same question. I mean, it's clear they can, right? It's clear patients can tolerate the therapy for 3 years and longer. But I think this is where we really should look at creative clinical design. We have seen great success with the Cleopatra, and it's because it's a really well-tolerated therapy. Mm-hmm. And I love your idea of trying to come up with a maintenance strategy so that we can use maybe a fixed dose of the cytotoxic ADC and then an immune therapy to maintain the remission. So this is an area where investigator trials are, I think, really welcome to sort of, I think, make these therapies practical.
All right. Thank you. For the sake of time, we should move on. Thanks for the great talk.